Okay. Hi, is that Jesse? Are you? Is that you, Jesse? Can you hear me okay? Can anybody hear me okay? Okay, we start in 20 minutes. See here. 20 minutes. And welcome everybody. Yeah, is that you, Jesse, with the hand up? Hola, Beck, ¿cómo estás? Sí, en 15 minutos, ¿ok? Tiene el link, ¿verdad? Ok, ok, nos vemos. ¿Qué dice?
Te ves muy bien con el pelo corto.
Oh, sí, menos peso. Ok, nos vemos. Greetings, Jesse.
Hello, John.
How are you?
Yeah, I'm great. How about you?
Very good.
Yeah.
You know, I was confused because there was someone else before you that came in and the name was just in Chinese. Dr. Salazar.
Okay, there.
How are you, John? Nice to see you.
Good, nice to see you.
How are things going down there in Miami?
Good, very good. The weekends are busy. You guys are busy all week. I just have the weekends.
Yeah, it's great to know you're working a lot and doing such a great job for the neurosurgical team in the world.
Well, we're getting a lot of Spanish. Tenemos mucho españoles ahora.
I see you have from Cuba and other countries also.
Yeah. Muy bien. Okay, bienvenidos.
Thank you.
Sí, Jesse, yo estoy confundido. Jesse, I was confused about the Chinese script of the person. Do you understand what I'm saying?
They are our technical staff to receive the signals so they can transmit this event on our website.
Oh, okay. So that's an associate of yours? So someone else is in here? They're welcome. They're welcome.
Yeah, they are our technical staff. Yeah.
Oh, okay, good. Welcome. Starting in about 9 minutes. Oh, this is Victor.
Hello,
Hello,
hola.
Victor.
Hello.
Hello, Jesse. How are
Hi,
you?
Victor. Yeah, I'm great. Thank you.
Jesse, I sorry for that, but I added two slides. I
No
say
problem. No problem.
thank you so much.
No worries. You're welcome.
Any suggestions for Victor this week, Jesse?
He can go as normal.
Good
Hello,
day, Ben.
Victor. Hi, John. How are you?
Welcome. Dr. Salazar is here from Ecuador.
Oh, Professor Victor Hugo, nice to see you.
Nice
Dr.
to
Vinchu,
meet- Nice to see you.
Hi,
Jorge.
How
Professor
are you?
Slada.
Fine. We send you our best regards from Ecuador.
Very nice to see you, Jorge Salazar.
The same. You're doing a great job, Victor Hugo.
Oh, thank you. You know, for me, it's a great honor to be invited by one of a giant neurosurgeon as Binshu. He's really amazing. He's really doing an amazing job around the world. Thank you, Binshu, for this great invitation.
Thank you. It's our pleasure and our honor.
Victor's getting some followers in China.
Yes, we already have more than 6,500 audience accumulated
Yeah.
for your last sessions. Yeah.
Yeah, I don't know if I mentioned it, Ben, but it's called shelf life. When you have something that's just going to maintain the value, it's like food, some food has a long shelf life. So Victor's webcast will have a long shelf life.
I hope sometimes you can both present your lectures with the Ecuadorian Society of Neurosurgery. I would like to invite you, both you, Professor Vinchu and Professor Victor Hugo.
Okay, great. Thank you.
Maybe you can join us sometime.
Thanks, Dr.
Thank you, Professor Slada.
Thank you.
Thanks.
Yeah, Ben, he has a very active group in Ecuador. very active neurosurgery group
Mhm.
that
Mhm.
usually they have webcasts every 2 weeks on a Friday.
Oh,
So Ben might be able to make it, Jorge, in the future.
Yeah,
And,
yeah,
and
great.
Victor.
will be great. Will be great.
Mhm.
That would be a Saturday. Let's see, Saturday afternoon. Let's see, Saturday 8. Yeah, Saturday morning, if possible.
Yeah, because of the change of the time. So, what time is the professor brings you? What time is there in your
Oh,
country?
it's 8 p.m. now.
8 p.m.
Yes.
Here's 7 a.m. 7 a.m.
Yes, it's very early. Thank you.
Day's just starting.
Mhm.
In Mexico is the same time as here in Ecuador.
Yes, Jorge, it's 7 o'clock.
Okay.
Yes, and a little bit cold.
Good morning.
Yeah.
So it's your winter.
No, we
No?
are in autumn.
Okay.
Yeah, but it's cold right now.
Mhm.
That's the reason.
It's very hot in Shanghai.
How many grades?
It's around the 40
Wow,
40
40
degree.
degrees.
Yeah. Yes.
too much.
That's very hot.
Yes. Very hot.
Let me
It's
just
also
put-
extremely hot in North America. Is it true, John?
in Miami.
No, not Miami. It's extremely hot in America and Canada. I think I heard
Oh.
that there's some fire
Oh,
in
it's
the
a heat
forest.
wave.
Yeah.
Yeah, there's some very funny things happening
Hmm.
as far as the weather.
Hmm.
Sometimes up north it gets hotter than the south, which normally it's the south that's hot. Here's Takashi. How many bypasses today, Ben?
Today, 7.
Oh, that's great.
Mhm.
That's amazing. Yeah.
Okay, Victor, you ready?
Yes, I'm ready.
Okay, here
Takashi,
we go. 10. Go ahead.
Bien.
Hey,
Buenas
Takashi, how
noches.
you doing?
Hi.
Ay,
Takashi.
buenas noches en Tokio,
Professor
Japón.
Takashi.
Mhm.
Have you met Jessie Takashi?
Yeah,
Yeah.
this morning.
She's a Chinese translator.
I tried to take Japanese translator.
Okay, ready to go, Victor? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the 6th in the series of neuroanatomy webcasts by noted neuroanatomist from Mexico City, Victor Hugo Perez. And I'd like to introduce Victor. I'll get the background noise. Go ahead, Victor. Thank you very much. It's all yours.
thank you. As I told you in several lectures, I feel very honored to be here with all of you. Especially, I am very grateful with Dr. Binshu, who has invited me to give these lectures. And of course, John Bennett, thank you so much. I'm going to share my screen. So, okay. Okay, I think we are ready. Okay, today I'm going to talk about the vascular anatomy of the spinal cord. And the first slide, I want to show you a video about injection of silicone, a red color for spinal cord arteries and color blue for veins. In this video, we observe the venous drainage of the spinal cord in lumbosacral segment that is carried out by several veins, as you can see in here. The drainage of these veins is carried out by this vein, especially this vein. This vein corresponds to the great spinal vein. With these injections, we can go to a very small veins and also arteries. Obviously, we are seeing the venous drainage in an inverse flow because I inject the veins. But maybe if we come back with the video, we could see the real venous flow like this. But in here, we can see this drainage of the veins. And very, very small veins can be filled. This image corresponds to the posterior part of the spinal cord. The great posterior spinal vein and its tributaries are observed. We also observe two posterior spinal arteries on each side of the posterior aspect of the lumbosacral segment. Here is the right posterior spinal artery and the left posterior spinal artery. And we can see a very nice anastomosis between these two spinal arteries. And this is the great posterior spinal vein, like this. It was Albert Adamkiewicz that in these years, he researched the spinal cord vasculature. This is a drawing obtained from an original article by Adamkiewicz, published in 1882 and 1881, showing arterial vasculature of the spinal cord and the bidirectional flow of blood in spinal cord vasculature. So here we have both vertebral arteries and the anterior spinal artery in the cervical segment. So here we have the Adamkiewicz artery, and in this drawing we can see the conus medullaris. Now, with these injections, we can go to the arteries and veins of the spinal cord in a real and amazing view of these anatomical injections. Adamkiewicz injected arteries and veins of the spinal cord using a special method. Teichmann mass consisted of these substances. Red color was injected with carmine sediment and Prussian blue for veins. So here we have these drawings made by Dr. Adamkiewicz. Look at these vertebral arteries and the basilar artery and these anterior spinal arteries. But now we can make beautiful injections in order to understand the vascular anatomy of the nervous system. So here, these vertebral arteries, and here we have the anterior spinal artery, basilar artery, and other branches coming from this vertebrovascular system. Spinal cords were extracted via a longitudinal midline posterior incision from the occiput to the sacrum. Anatomic dissection was performed until reaching the vertebral lamina. Laminectomies were performed from C1 to L5. The spinal nerves were cut with care so as not to lesion the dura mater. Red natural latex was injected into the Adamkiewicz artery under moderate pressure and close visual inspection to avoid contrast extravasation. The injection was continued until latex filled distal small caliber arterial vessels, including the posterior spinal arteries. So let's go to see this video. This is an injection of this silicone. Here we have the Adamkiewicz artery, and in here we can see also the injection of a very thin vessel. Let's go to see again this, because look at this. Very, very small arteries can be filled with this preparation of silicone. The great anterior radiculomedullary artery. This is known also as Adamkiewicz artery. This artery is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin. The preoperative localization of this artery is very important in the surgical transthoracic spine procedures. Here we have this beautiful Adamkiewicz artery. This artery is going to the conus medullaris and also has a branch that is going to the thoracic segment of the spinal cord. The artery of Adamkiewicz in the left side was present in 45 specimens, and the right side was present in 5 specimens. This is a study made in CIFO, here in Mexico. So it was a study about 50 spinal cords. And as I told you, 45 were in the left side and 1 in the right side. Here is one artery of Adamkiewicz in the right side of the spinal cord. And this is the distribution of this artery. Adamkiewicz artery in the anterior aspect of the spinal cord, going to the conus medullaris, where this artery is divided in 3 arteries. One of these going to the filum terminale, and 2, one in the left and one in the right side, going to the posterior aspect to the spinal cord. Although variability exists to the overall caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. The most important radiculomedullary artery is the arteria radicularis magna, otherwise known as the artery of Adamkiewicz. This artery arises in the thoracolumbar region between T8 and L2 in 75% of cases, and has a diameter in an average of 1 millimeter of diameter. Here we can see the conus medullaris, the anterior spinal nerves, and this is the usual form of this artery. This artery in the conus medullaris has 3 branches. One of them going to the filum terminalis, and the other 2 is one to the left side and one to the right side. These arteries are the posterior spinal arteries. This is the lateral aspect of the spinal cord in the conus medullaris, and we can see 2 posterior spinal arteries on the right side. In here, conus medullaris, the anterior spinal nerves, and posterior spinal nerves. So this is a big difference between the artery of Adamkiewicz and the thoracic spinal arteries. A big difference, because the diameter of this For example, it could be 1 millimeter of diameter, and this spinal cord thoracic arteries could be 300 micras, 2 or 300 micras. The preoperative localization of the Adamkiewicz artery is very important in surgical transthoracic spine procedures, and the anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. In this case, we have the highest level of the Adamkiewicz artery. So this is cervical segment and thoracic segment. We can see in here C1, 2, 3, 4, 5, 6, 7, and 8 spinal cord nerves. And then 1, 2, 3 spinal nerves, and this Adamkiewicz artery arises in this third segment of the thoracic spinal cord. It was the highest level. So this is the thoracic segment, and look the long trajectory of this Adamkiewicz artery. This is a close view of the Adamkiewicz artery arising from T3, the third thoracic nerve in here. And the lowest level, this artery arises from left L2, the second lumbar nerve in here. Here we have the lowest level in this 50 spinal cords studied. So look, this beautiful Adamkiewicz artery, and this artery is giving a branch to the thoracic segment. Let's go to displace these spinal nerve roots in order to see the lateral aspect of this spinal cord. Here we have Adamkiewicz artery, the anterior aspect and posterior aspect. This is the dentate ligament, and look, the anastomosis between this posterior spinal artery with the anterior spinal artery. This is lateral aspect. And this is very important. Some lectures ago, Dr. Binshu asked about the injection of this silicone into the arteries. And the question was if these injections enhance the diameter of the arteries. Could be, but I think the enhance of the diameter is not of great importance, because look at this. Very, very thin arteries can be injected in the spinal cord. I think the most important tip for doing this injection is to get a fresh spinal cord. This is the distribution of Adamkiewicz artery. The spinal level in this column, the left-sided artery, we can see here that most of this Adamkiewicz artery arises from T9, left level. And when this artery arose from the right side, it was in the T10 level, only 3. Here we have a picture with 3 spinal arteries, great spinal artery. 1, 2, and one of them was really, really thin, like an accessory artery. This is a close view. And let's go to see the anatomy of the great posterior radiculomedullary artery. Understanding the vascular anatomy of the spinal cord is very important for image interpretation and endovascular and surgical management of spinal cord vascular malformations. Advances in diagnostic and therapeutic interventions have led to a need for more detailed and specific understanding of the microvasculature of the spinal cord. In particular, attention to the anatomic variations of the smaller caliber circulatory supply to the spinal cord allows tailored management of a specific patient. Here we can see this great posterior radiculomedullary artery. Here is the distribution of this artery in the posterior spinal cord aspect. This is a video
El posterior aspect
in
of
which
the spinal cord,
we can see
filum terminale, caudequina, el conus medullaris. We can see the veins of the posterior aspect of the spinal cord. This is a small vein. This is the aspect, posterior aspect of spinal cord.
and look at this. Here we have the posterior spinal cord artery, the great posterior radiculomedullary artery. Here we have this beautiful artery. This work was made at Forensic Sciences Institute in Mexico City. So the existence of a great posterior radiculomedullary artery has attracted little attention and has been a matter of debate. So this is very, very important because various authors postulate such a vessel as Gillian in 1958, Las Ortes, same year, Romanes in this year, and Jellinger. But others do not mention it or even deny its existence, like Corbin, Clemens, Dindian, and Domis in 1980. According to Jellinger, a large posterior radicular artery is seen caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels, diameter 350 and 500 micras. Its height is more caudal than that of the anterior radicularis magna artery. So there is no doubt about the existence of this great posterior radiculomedullary artery. Here we have the Adamkiewicz artery, and here the great posterior radiculomedullary artery. The artery of Adamkiewicz in the spinal cord was injected, as we have seen in this lecture, but in this case, I also injected this great posterior spinal cord. Let's go to look this video.
This is a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. Great posterior radiculomedullary artery.
In this other video, I displayed these spinal nerve roots, and let's go to see.
Here we have the posterior spinal artery that is coming from the Adamkiewicz artery. This is the posterolateral aspect of this spinal cord.
In this picture, we can see both spinal cord arteries. Here, this branch coming from the Adamkiewicz artery in the anterior aspect. This artery continues in the posterior aspect as posterior spinal cord. But this artery is doing a really nice anastomosis with the great posterior radiculomedullary artery. Look, this beautiful anastomosis between this artery, great posterior radiculomedullary artery, with posterior spinal cord artery coming from the Adamkiewicz artery.
Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery. Let me show you in this video a very significant feature. So in this side of this spinal cord, the left side, we don't have an anastomosis between the posterior spinal cord with the Adamkiewicz artery at the conus medullaris.
Okay. In the other side of this spinal cord, this is the left side, we do not have a good anastomosis. Of course, it is an anastomosis with very, very thin vessels, as we can see in this side. For example, in this spinal cord, there was not a great posterior radiculomedullary artery. Instead, there were several radicular arteries. Here, this one, this another one. But they are very thin. A variable number of radicular arteries originating from segmental arteries or homologous vessels make arterial contributions as lateral feeders along the course of the spine. These radicular arteries are of a small but differing calibers. Most of these radicular arteries supply nerve roots, the dura, or the pial plexus. Only a few of these radicular arteries specifically provide arterial supply to the collateral network of vessels supplying the spinal cord. These vessels are specifically termed radiculomedullary arteries. A great posterior radiculomedullary artery was identified in 72% of spinal cord specimens. This total included specimens in which unilateral and bilateral GPRAs were found, as well as a single case in which 3 great posterior radiculomedullary arteries were evident. In 26 of the specimens, a unilateral left-sided GPRA was present, as we can see in here pictures. So this is posterior radiculomedullary artery, this one, posterior aspect, and this Adamkiewicz artery in the anterior aspect. Look, the anastomosis with these thin vessels. In 22% of the specimens, bilateral GPRAs were present, like in this case. Here we have one in this and another one. In this specimen, we had 3 great radiculomedullary arteries. Distribution of this artery is, this is the spinal level and left side and right side. In the left side was more common in 9 specimens, and in right side in 9 at this level, T12. There is no doubt about the existence of this artery, although this was denied by several authors in the last century. This artery is conclusively present in most individuals. Understanding this intricate anatomy and its variations is critical for addressing vascular malformation of the spinal cord. A better understanding of this spinal cord circulation will lead to reduced risk of surgical and endovascular spinal and aortic procedures. So let's go to see the difference between 2 spinal cords. Let's go to see the venous drainage. In this case, we can see the distribution of the veins in the posterior spinal aspect. And in this case, in these videos, we can see an anatomical variation of the venous drainage of the spinal cord. What is the difference between these two spinal cords? I'm going to repeat these videos and look. For example, in this video, in the inferior video, we have several veins draining this spinal cord. Several. 1, 2, 3, 4, 5, 6, 7, 8, 9. We can see several veins draining this spinal cord. But in the superior view, we have only 1, 2, 3, and this that is a greater than the others one. So this is very important to know the distribution of the venous drainage. Here we have the great spinal anterior vein, this one, and its diameter of the veins is about 0.8 millimeters, and it could be from 0.46 to 1.32, 1 millimeter, 1.32. Beautiful picture of this posterior, this is the anterior aspect, Adamkiewicz artery and great spinal anterior vein. Let's look some pictures about this, and here we have this anatomical variation of this vein. This is the posterior spinal vein, 1.48 millimeters, this one. And the posterior spinal arteries. This is like a malformation of the spinal veins, veins. So in other slides, I'm going to show you a malformation. In here, we can see the dissection of the arachnoid in the posterior aspect of the spinal cord. So let's go to compare this video with the next one. This is the anterior aspect. This is very important. Let me explain to you Why? Is very important to know this. This is anterior aspect, and look that dissection of the arachnoid is very easy in this case, very, very easy in the anterior aspect. So very easy to dissect arachnoid in this case. Very easy to dissect, but in the posterior aspect is not easy to dissect, as you can see in here. There are several attachments from this arachnoid membrane to the vessels. So for the spine surgeons, this is very important to make a careful dissection of this arachnoid membrane. Let's go to the next. Okay. And here we have a spinal dural arteriovenous fistula. A progressive neurological damage due to a vascular disorder of the spine has been recognized for more than 40 years. The advent of selective spinal catheter angiography has allowed the identification of the most common type of spinal cord vascular malformation, like this one. The spinal dural arteriovenous fistula, or type 1 spinal vascular malformation. These lesions are defined by abnormal connections between a radicular feeding artery and the coronal venous plexus of the spine without an intervening capillary bed. The actual fistula site is at the dural sleeve of the nerve root, and the pathophysiology underlying the neurological symptoms and signs is well understood. So here we have this spinal dural arteriovenous fistula that I saw in my dissections. This text was taken by this article, Clinical Presentation and Prognostic Factors of Spinal Dural Arteriovenous Fistulas, an overview by these authors, Giuseppe Lancino. And I took these pictures from work from Giuseppe Lancino, and in here we can see these arteriovenous malformations and at the surgery. And here we have this feature, this malformation that I found in my dissections. It's really impressive to work with these vascular malformations of the spinal cord. This work was published in this journal, American Journal of Neuroradiology, in 2019 year. So, vascular anatomy of the spinal cord is really amazing. Thank you very much for your attention.
Victor, Ben?
Thank you, Victor. Thank you for your nice presentation. And we actually have a very limited chance to see all the anatomy of the spinal vessels because only when we do the operation, we only expose very limited space and even the SDAVF. It's a very nice case. Thank you.
Thank you so much, Bin. Thank you, thank you. Thank you to all of you.
Jorge, would you like to say a word?
Hello.
Yes, yes.
Okay,
first
thank you
place.
very much. Thank you.
Hello.
It was very nice presentation, and really, it's very important for the spine surgeons about the Adam Quich artery, and so we are faced with in clinic with difficulties because in spinal cord injury we have a level of neurological deficit, but the real fracture and injury is different, and we see the importance of arteries and veins in spinal cord, especially in ischemic events, and it was very useful, very nice presentation. Thank you, Professor Perez. Hello, Professor Salazar and Professor Zhu. Thank you for your invitation as well. Thank you very much.
Thank you, thank you.
Ahmad is from
And your first-
Afghanistan.
Yeah.
Welcome. Go ahead,
I would
Jorge.
like- Yes, in the first place, I would like to congratulate Professor Victor Hugo Perez for such a wonderful presentation. Seldom we can see those beautiful pictures of the arteries and veins, and it has been a good remembrance of how is the anatomy, especially to recognize the artery Adamkiewicz, which starts at the T8, T9 on the left side, especially. So this is very important to remember when we are performing surgery at this level of the spine. And also very important, the presence of the great posterior radicular artery in 72% of the cases, which starts along the radicular thoracic nerves. Sometimes when we are performing surgery of spinal tumors, in some cases, it's indicated to cut the radicular nerves because they say it has no motor function, but it's very important to consider first the presence of this great posterior radicular artery, and also going to the veins. The great spinal anterior vein and the posterior spinal vein are very, very important to know. Sometimes if we produce a lesion of these veins, an infarction can be produced within the spinal cord with disastrous neurological damage. So it's a very, very practical, this presentation, Professor Victor Hugo Perez. Thank you very much for showing us this beautiful pictures and anatomical details. Thank you.
Thanks for your comment, Jorge Salazar. Thank you so much.
Takashi, would you like to weigh in?
Yeah, I'm Dr. Takashi Gon from Tokyo, Japan. Thank you for the nice presentation and nice picture. Spinal anatomy is very difficult for us to understand, and especially Adam Kiewicz artery is very clearly identified. So it is very important, both spinal surgery and spinal endovascular surgery. And even if that patient has a spinal AVM, is very difficult to diagnose and treat. So we are very informative lecture, and for our colleagues, our residents in Japan. Thank you so much.
Thank you, dear friend Takashi Kon.
Takashi is helping to televise it in Japanese in real time. Jafar, how you doing? And welcome. Jafar, I believe, is a medical student from Iraq, correct?
First of all, good evening from my location to everyone. I am Jafar Muhammad Sabbar, fourth stage medical student from Iraq, Al-Anbar University. I am glad to be here to listen to Dr. Victor and to see how amazing the anatomy of blood vessel of the spinal cord. I am glad to be here to listen to such wonderful, such beautiful and brilliant neurosurgeon. Thank you for link to me to listen to such a lecture. Thank you, Victor, for this presentation. I'm glad to be here.
Thank you, Jafar. Thank you.
Welcome, Jafar.
Salam.
Saeed, do you want to say hello? Saeed Taha from Africa.
From Oriental Island. Hello. Hello, everybody. Hello, John. How are you?
Hello, Saeed.
Yeah. Victor.
Hello.
Thank you for this nice presentation with this anatomical studies. So for sure, it's important to know the anatomy of the vasculature, medullary vasculature for clinical and surgical pathology. As we know, there are some region like the middle thoracic medulla where the vasculature is poor than the other side, and to be gentle in during the surgery, to be aware of about complication if we sacrifice the small vessel in this region. So thank you very much, Victor, for the nice video, nice anatomical studies, and I'm happy to do next week. Next studies, anatomical studies with you.
Thank you. Thank you. Thank you.
Thank you. Saeed's from Reunion, an island off the east coast of Africa. So, okay, welcome, Saeed.
Thank you very much.
Ahmad, do you want to say a word?
Yes, I would like to say as well, assalamu alaikum to Jafar and Professor Saeed Taha. Assalamu alaikum, kaifa halakum?
Alaikum salam. Thank you. Thank you.
Thank you. Nice to see you.
Nice to meet you.
Okay. Okay. I'm from Afghanistan. Yes.
شكرا.
Stay tuned for Afghanistan Neurosurgery Grand Rounds.
Yes. Yes.
Okay, I guess we'll wrap it. Does anybody have any closing remarks they'd like to say? I guess we're all
Professor
set.
Bennett, as I previously in the previous webinars and conference, I told that in Afghanistan, this is not allowed for cadaver dissection. And we like to draw attention, you and Professor Perez, about some courses, sponsor some courses or fellowship or scholarship for dissection and anatomy and working on cadaver, if it's possible for our young neurosurgeons.
Yeah, we'll talk about that, okay?
Okay. Okay.
Okay, I'd like to thank everyone. Ben, thank you very much for coming and putting this together and facilitating the televising of it in China, where it's doing very well. The 6 webcasts are doing very well in China. Thank you, Jorge, for coming. Takashi.
John Bennett. John Bennett.
Go ahead.
John, Binshu, do you have a screenshot today for the participants in the webinar? A screenshot.
Metion? Yeah,
Yeah,
let me go, Victor. Let me take a second here.
Now we
and-
have 6,700, more than 700.
Do you have a screen?
Yes,
Can you share? Can you share?
John,
the
can you share the screen
Yeah, I'm doing.
of the
I'm
WeChat?
doing it right
Mhm.
now. Just give me a second. Getting the translated page. I'm sorry about we're having an internet slow up here.
Later, John, no problem. Later.
Yeah,
Yeah,
okay,
yeah.
Victor.
It's
For some reason, I'm having a little slow connection there.
yes, it's 6,719. Yeah.
Thank you.
It's a different way of
Thank you,
screen
thank you.
sharing.
Victor, Professor Victor, I can send you a screenshot of the live stream page after this lecture.
Yes, Jesse,
There you go.
Jesse, thank
Thank-
you, thank you very much. Thank you, Jesse, for translation. And
You're welcome.
The last lecture 1 week ago, you had a toothache.
Yeah.
That's right. Yeah,
I
recovery.
removed my wisdom teeth last week.
They recovered nicely. So thank you, everybody. And
Thank
we'll
you.
keep in touch about the next project. Thank you.
Thank you. Bye-bye.
Gracias. See you then. Thank you.
Recording there.